Good morning everyone. First of all, I would like to thank the organizers for their invitation and to share with you what has been done in Brazil regarding the secondary prevention of fractures through FLS. It is an activity that I have dedicated myself in recent years, and I am very proud to say that we were pioneers in this area. This is my declaration of conflict of interest. Brazil. In the map of best practice of IOF Capture the Fracture campaign, there are 16 FLS recognized. In 2016 it was the country that most included FLS in the map of best practice. Same number of FLS included as France in the map of best practice. Number of FLS included in map of best practice greater than Canada, Germany, Italy, Switzerland, Australia, New Zealand, Russia. Number of FLS included in map of best practice less than Spain, United Kingdom, United States. A little bit history. In 2008 at the ASBMR Congress in Montreal, I attended a lecture by Professor Joseph Zuckerman, then president of the American Academy of Orthopedic Surgeons. Professor Zuckerman has published papers on the epidemiology of hip fractures. The theme was, why does the orthopedic surgeons not treat or do not refer for treatment of osteoporosis after a minimal trauma fracture? The professor replied that because he is very busy, because his role is to treat fractures, because he is a surgeon, because he does not deal with osteoporosis, because Medicare pays little for the report. I left the lecture thinking, I am an orthopedic surgeon. I deal with osteoporosis. I work in a general hospital. Why do not you develop the department to treat these patients who have had a fragility fracture? In 2011 we founded Prevrefrat, which means Refractive Prevention Program, in the Federal Hospital of Ipanema, a federal public hospital in Rio de Janeiro. The main features of the program were exclusive care for patients with fragility fractures, complete diagnostic evaluation, X-ray, DXA, lab, multidisciplinary team guidelines, clinical protocols, free delivery of medication, treatment adherence, physical activity, fall prevention. At that time I could not imagine what words meant like FLS, secondary fracture prevention, capture the fracture. In 2012 I was invited and I had the pleasure to collaborate in the ASBMR Task Force report on the secondary fracture prevention. In 2013 I had the honor of collaborating with the Capture the Fracture Best Practice Framework. This was the first Capture the Fracture map of best practice presented at the World Congress in Rome in 2013. Our FLS was already included. In 2014 we were awarded the Gold Star in the map of best practice. Let's talk about skateholders. FLS and secondary prevention of fractures are not official programs of the Brazilian Ministry of Health. The anti-osteoporosis drugs distributed in the Ministry of Health pharmacies are alendronate, risedronate, raloxifene, calcitonin, pamidronate, conjugated estrogens. Ibandronate, teriparatide, zoledronate, denosumab are not distributed. Let's talk about adherence to treatment. This article from the year 2012 demonstrates adherence to treatment in a 4-year follow-up with alendronate, risedronate, raloxifene, teriparatide and strontium ranelate. Here in the blue band demonstrates a group that had adherence that ranged from 75 to 50%, for example a drug of weekly use. If the patient takes 3 tablets per month, the adherence is 75%. If the patient takes only 2, the adherence is 50%. Here in the green belt demonstrates a group that had adherence less than 50%. Why was it divided like this? The classic paper by Ethel Cyrus demonstrates that adherence of 75 to 50% compromises effectiveness, while below 50% it is as if the patient was not doing any treatment. You can check on the chart that after 1 year no one had adherence above 75%. This article also from the year 2012 demonstrates adherence to treatment in 1-year follow-up with bisphosphonates monthly use, weekly use, daily use, raloxifene and strontium ranelate. Here are the adherence to treatment groups, and adherence greater than 75% did not reach 5 months. My personal opinion. The use of drugs related to historical low adherence, in patients with so higher risk of fracture is risky. "65% of subsequent fractures occur in the first 2 years. If, at least, in this critical period, we could use 6-month or annual drugs, the result would be better." Let's go back to skateholders. These are the modalities of medical assistance in Brazil. Health insurance plans, self-management plans, insurance companies, federal government hospitals, unified health system, and here the approximate cost of surgical fragility fracture without adverse events. In health insurance plans, self-management plans, insurance companies, because of the cost of the fracture there are no restrictions for the use of zoledronic acid or denosumab. In the federal government hospitals and unified health system the drugs used are those distributed by the Ministry of Health, alendronate and raloxifene. Health insurance plans, self-management plans, insurance companies, has been growing market for the FLS. We will present some results from our FLS. We observed in the literature that the results are demonstrated from the increase in the number of patients who perform DXA or who start to use anti-osteoporosis medication. What we will present here is directly linked to reduced rates of new fractures in patients treated by our FLS. Still, according to the literature, the reduction of new fractures in FLS generally ranged from 30 to 60%. Most FLS use alendronate primarily. Our FLS gives preference to zoledronic acid and denosumab because of better adherence to treatment. In March 2016, we published in the Brazilian Journal of Orthopedics an article on secondary prevention of fractures and reporting the experience of our FLS. Over a period of 3 years and 10 months, 450 patients were followed up and 12 cases of fractures occurred. None of these were hip fractures. The rate of reduction of subsequent fractures was more than 97%. At the World Congress in 2016, we present a paper in which we access the ability of our FLS to directly reduce the rate of refractures in patients with a history of fragility fractures. We evaluated 553 patients, men and women over 50 years of age with minimal trauma fracture. We had 26 new fractures, with a reduction of 95.3%. At the World Congress in 2017, we present the evaluation of 196 patients, men and women over 60 years old with fragility fractures. We evaluated patients who had fracture of the proximal femur or who had more than one vertebral fracture or who had one vertebral fracture plus one other fracture. These patients can be classified as patients with imminent risk of fractures. Of the 89 patients with proximal femur fracture, 8 new fractures. Of the 30 patients with vertebral fracture and distal radius fracture, 3 new fractures. Of the 15 patients with vertebral fracture and proximal humeral fracture, 3 new fractures. Of the 58 patients with more than one vertebral fracture, 4 new fractures. Here is the reduction in the number of subsequent fractures in each group. Of the 196 patients, 21 patients with new fractures showed a reduction of 89.2%. Evaluation of the impact of a secondary fracture prevention program in a health insurance plan. Objective: to evaluate the impact on the global reduction in the number of surgical procedures in fragility fractures in a health insurance plan at the end of the second year of Prevrafrot. Participants: patients over 50 years of age with codes related to fragility fractures. Methods: database search from 2014 to 2016. Analyze. Primary endpoint: absolute reduction of surgical procedures in spine fracture, femur fractures and other surgical fractures, after 2 years. Results: reduction of spinal surgical fractures by 50% compared to 2014. Reduction of surgical fractures by 33% compared to 2015. Reduction of femur surgical fractures by 66% compared to 2014. Conclusion: Previfrot showed effectiveness in the overall reduction in the number of fragility fractures that require surgical resolution. The most relevant reduction occurred in the fractures with higher morbidity and mortality and higher assistance costs, spine and femur fractures. Final considerations. The projections estimate that the number of hip fractures per year in Brazil should reach 160,000 by 2050. That means one hip fracture each 3.28 minutes. No health system can support this demand. IOF recently worsened this expectation. Latin America is the most rapidly aging region of the world between 2015 and 2030. In Brazil, the number of hip fractures will more than double. From 80,640 cases in 2015 to 198,000 cases in 2040. How many countries are there in the world? According to the United Nations, there are currently 193 countries. 5 countries represent 48% of the world's oldest in 2015. 19 countries concentrate 75% of the world population of 80 years or more. Brazil is one of these countries. This is the message that comes from the United States. The use of bisphosphonates has dropped 50% in the last 10 years. It seems clear to me that this directly influences the number of fractures. If it happens in the United States, we can imagine what happens in other countries. Unfortunately, maybe it's time to rethink the care we provide today to prevent fragility fractures. But it can be so much better. Destinating efforts and resources for who really need. Avoid the first fracture. If you cannot, do not let the second happen. Thank you for your attention.